Everybody, we'll go ahead and get started here. Welcome to the last session of the day. We'll be talking about advances in vessel wall imaging. I'm Scott McNally from the University of Utah. This is Bing Tian. We're both neuroradiologists interested in vessel wall imaging. So I'm going to go ahead and introduce the first speaker. I'd like to introduce Dr. Zhihai Zhao. He'll be talking about joint carotid and intracranial artery vessel wall imaging techniques and application. And for all these speakers, because we're a little bit behind, we're just going to move the questions to the reception. Thank you.
Thank you for the introduction. I have nothing to declare. So hello, everyone. So today I'm very happy to discuss the information about the joint vessel imaging for intracranial and extracranial carotid arteries. So today I'm not going to cover the imaging processing part because time limit. So I will start from the background. Actually, the stroke is the leading cause of death in the world. And the vital plaque in intracranial artery or carotid artery will trigger the ischemic stroke. So as a systemic disease, atherosclerosis frequently involves multiple vascular beds. Previous studies demonstrated that the coexisting intracranial and extracranial carotid artery atherosclerosis is prevalent in stroke patients. The prevalence is up to 43%. Investigators also found that coexisting atherosclerosis will increase the risk of a recurrent stroke in symptomatic patients. So evaluating the coexisting atherosclerosis is very important. It is well established that the vulvar plaques are compositionally driven by these features like the large lipid core, intraplaque hemorrhage, or fibroside rupture on histology. So only measuring the luminosynostosis will underestimate the plaque severity due to the positive remodeling effect. So MR vessel imaging can directly visualize the vessel wall itself, and then it will be the ideal imaging approach to evaluate the plaque vulnerability. So for the imaging modalities to detect the coexisting plaques, the DSA, CTA, and MRA can visualize the luminostenosis, but there is no vessel wall information. Apparently, vessel wall imaging can be an ideal approach to image both intracranial and extracranial carotid artery vessel wall simultaneously. So previously, actually the 3D vessel wall imaging, such as the 3D merge sequence, the snap imaging sequence, and space or vista or cube or matrix, these imaging sequences have been largely utilized to characterize atherosclerosis in carotid artery or intracranial artery. So in 2016, Dr. Chun Yuan and Dennis Parker stated that 3D plaque imaging will offer flexible imaging plane, large coverage, multivascular beds, capability, and even can be used in the screening. So I totally agree with this opinion. So here I'd like to share the information about the development or optimization of the MR vessel imaging techniques for joint vessel imaging. So in terms of the technical concern, we need to consider the following points, like large coverage, efficient plaque suppression, isotopic spatial resolution, and acceptable scan time for joint vessel imaging. So our group developed a multi-contrast 3D joint vessel imaging protocol, including merge, VISTA, and SNAP imaging sequences to provide the T1 weighted, T2 weighted, and hyper T1 images for imaging the both intracranial and external carotid arteries. So after optimization of the imaging parameters, we obtained high quality visual images for both intracranial and extracranial carotid arteries at the one scan. So actually for each sequence, the scan time around 5 minutes, it is acceptable in clinical settings. So however, the spatial resolution for this imaging protocol is 0.8 millimeter isotropically, which is not good enough for intracranial vasculature. So to increase the spatial resolution of this imaging protocol, our group further optimized the imaging parameters to push the spatial resolution to 0.5 millimeter isotropically, so we can also obtain the high quality images for T1 weighted imaging, but the SNR is a little decreased for the T2 weighted imaging, but the image quality is still acceptable. So we validate this imaging protocol by histology, in qualitative or qualitative evaluating the plaque features. So there is a moderate to strong agreement between joint visual imaging and histology. So, but we only validate this technique at the carotid artery vascular bed. Actually, this 3D joint visual imaging protocol or imaging technique can be also performed at the other platform like Siemens and United Imaging at 3 Tesla MR scanner. So we can also speed the acquisition by using the acceleration algorithm. So even at the 5 Tesla MR imaging platform, we can also obtain high quality the 3D joint visual images. So even for the spatial resolution is 0.5 millimeter isotropically, and the scan time is just 5 minutes. So because in this imaging, we utilized the AI-based acceleration algorithm. So to ensure the image quality for the joint visual imaging, we have to design the dedicated coil. So in 14 years ago, actually our group built a 36 channel coil to cover head, neck, and chest. We can scan the visual imaging sequences and to cover the whole area. So although this coil is complicated, but it is very useful. So another group from Shenzhen, China, also designed 32 channel joint head and neck coil and 48 channel joint head, neck, and chest coil. They also obtained high quality joint visual images for both intracranial and extracranial vasculatures. So here I'd like to share the results about using this technique to investigate the coexisting atherosclerosis. So our group firstly utilized the multi-contrast 3D visual imaging to investigate the coexisting atherosclerosis in intracranial and extracranial carotid artery. So we found that in stroke patients, so if the patient had carotid plaque, so the coexisting intracranial plaque, the prevalence is up to is over 77%. This is very high. And we also find that plaque number of coexisting atherosclerosis is an effective indicator for the risk of acute infection in brain. So we also find that the enhancement of coexisting atherosclerosis is also a significant indicator for the ischemic stroke. In a prospective study, investigators found that the coexisting intracranial plaque features, especially the hyperintense T1, this is the pattern coexisted with carotid plaque, is the highest predictor for a recurrent stroke compared to the other plaque features. So this is very interesting result. So another similar study also showed that both plaque number and plaque enhancement of coexisting atherosclerosis are significantly associated with the future events of cerebrovascular disease. So our group also tried to evaluate the coexisting atherosclerosis in 3 vascular beds from intracranial artery to carotid artery and aortic arch. We scanned all the images at each patient, but the sample size is too small, just 52 patients. So we find that in this study population, the prevalence of a coexisting plaque in all 3 vascular beds is 13.5%. So this is a interesting number. We also find the plaque burden in the entire 3 vascular beds is the highest predictive value for the ischemic stroke. So here is an example, so we can appreciate high-risk plaque in intracranial artery, carotid artery, aortic arch. So for this patient, also developed the acute infarction in brain detected by DWI. Here I'd like to summary. So this is a interesting topic actually. So we just discuss the joint vessel imaging for both intracranial and extracranial carotid artery atherosclerosis. So actually, this imaging technique is an effective approach for characterizing the coexisting atherosclerosis, but we do need a dedicated joint head and neck coil to ensure the image quality. Otherwise, so we cannot get acceptable image quality. So the imaging protocol does need to be standardized. We do need to consider the spatial resolution, which resolution is good enough, and the coil, the use of a contrast agent, and we just scan single sequence or multi-contrast imaging sequences, etc. So the image interpretation or diagnosis is a big issue because for joint vessel imaging, we can get huge data. So a lot of slices. So how to diagnose, how to efficiently interpret all these images. So I think the AI-based analysis tool might be a good solution. So this is all my slides. Thank you very much. Thank you.
Thank you very much. Again, we'll move the questions to the reception. Next, I'd like to introduce Dr. Mahmoud Mosabasha. He'll be speaking about comprehensive vessel wall imaging and clinical stroke assessment.
Much. We'll be talking to you about vessel wall imaging here in stroke. And just as a quick mention, this is all work related to condition in Alabama, Vermont. Sorry. Gotcha. Hold it. Okay, so I'm going to be talking about the evidence to support the value of vessel wall imaging in acute stroke. We'll talk about the approach to establishing a comprehensive vessel wall imaging program, as well as the value and applications of stroke and vessel wall imaging. So first, in terms of etiologies of stroke, we have a few major categories: large artery atherosclerosis, cardioembolism, and undetermined etiology of stroke, whether it's ESIS, embolic stroke of unidentified stroke, or cryptogenic stroke. These are the three major categories that we really look at, and that we're really performing MR for that evaluation. They're generally in the 20 to 25% range in terms of etiology. We're not going to touch on small vessel disease too much, because that's usually not something that vessel wall imaging and vascular imaging really impacts. And then there's a small category of everything else that represents 5%, and I will show you some cases from that category. But in terms of the vessel wall imaging that we're doing, what we're really working on is trying to determine the etiology of stroke so that we can prevent secondary stroke. We're not trying to treat and manage the current stroke, but it's just future prevention. And in general, in terms of stroke, the risk of a second stroke is around 12% across the board. It differs slightly between the different etiologies of stroke. And in addition, in terms of that risk is much higher in the first 3 months post-stroke event. You know, it slightly tapers off as you go further away from the stroke event, but it's really that early window where we want to define what's causing the stroke. We want to appropriately treat it and prevent the future stroke. So in terms of vessel wall imaging, it's something that we've been doing for a while, and a lot of institutions are doing it. This is a survey that we published in 2022 and performed in 2019. And we found that about 55% of groups surveyed were performing vessel wall imaging, and they were performing it at a high rate. More than 75% were performing it at least 2 times per month. This was not just academic groups. It straddled both academic and private practice groups, as well as groups in the US and internationally. So in terms of vessel wall imaging and evaluation, a couple points of data I want to provide for its support in stroke assessment. This is a study we published a couple years ago, where we used one of our quantitative software algorithms called MoCA to evaluate plaque burden. And what we evaluated those plaque burden characteristics, we found that there was no relationship between the thickness of a plaque and the degree of stenosis. So, and that's really predicated on the fact that, as was mentioned in a few other talks, plaque a lot of times outwardly remodels. And so in that setting, MRA and CTA don't really do a good job of evaluating plaque burden and can't really establish stroke risk or stroke risk stratification in the setting of atherosclerosis. And these are another 2 studies we published, in which we're also looking at luminal and vessel wall imaging in terms of assessment of plaque. And here's just a couple examples of a patient who has 2 plaques, a distal basilar artery and a proximal basilar artery plaque. When you look at the cross-sectional imaging, you can see that the burden of both of these plaques is about the same, but the main difference is the degree of stenosis there. So we can see this distal basilar plaque very well. It's causing a lot of stenosis, and it's appreciable on DSA and MRA, but the proximal plaque you cannot see at all here. So just again, highlighting how luminal imaging may miss the target of what we're looking for with it. And then another study in terms of looking at strokes, where we looked at patients with perforator territory infarcts or corona radiata infarcts on 7T. And what we found was that in terms of those patients with those deep infarcts, involvement of the perforator branches as well as irregular surface of the plaque were independently associated with strokes in these areas. And in this example, you can see there's maybe a slight indentation along that superior aspect of the MCA in association with that perforator branch, but really tough to prospectively call it an MRA. I think that would go missed 99.9% of the time. We do the vessel wall imaging, and we can clearly see that there is an atherosclerotic plaque there along the superior wall of the MCA. And this is from another study that we published as part of the SMRA, an education paper. And one case that we highlighted in there was this case, where we see there is some ischemic changes involving the corona radiata here in that perforator territory. When we look at the MRA, we can see that there's a clear difference in terms of perforators on the right versus the left. And you see that little, again, indentation along the superior aspect of the MCA. This would not be called as a stroke etiology, and it also would be very tough for a radiologist to prospectively detect that little indentation. When we do the vessel wall imaging, you can clearly see that there is an atherosclerotic plaque along that superior aspect of the MCA, which is the reason why these perforators are getting picked off and why you're developing ischemic changes here. This was a study from China in which they looked at patients with ESUS and compared them to small vessel disease and looked at the atherosclerotic burden. What they found was that there was significantly more atherosclerosis ipsilateral to the stroke in ESUS patients than the contralateral side, while it was equivalent in small vessel disease patients, indicating a difference in terms of stroke plaque burden and association with stroke between those two cohorts. In addition, in the ESUS patients, the strongest associations with ESUS were plaque remodeling index, or that likelihood that plaque grows outward. So again, that plaque outward growth is a vulnerable feature for atherosclerosis. And another study from the Toronto group in which they looked at how vessel wall imaging affected the etiology of stroke. And they reviewed cases without vessel wall imaging and then with vessel wall imaging. And they found that there was a significant change in the stroke etiology when they included vessel wall imaging in 55% of cases. And the biggest movers were going from nonspecific arteriopathy and then going from intracranial atherosclerosis as the etiology, which went from 23% of cases to 57% of cases once vessel wall imaging was included. And this is one of our studies where we looked at how accurate we were in terms of diagnosis for a vasculopathy when we included vessel wall imaging or before the vessel wall imaging is included. And we found that without vessel wall imaging, that accuracy was around 30 to 40%. But once we included vessel wall imaging, that percentage accuracy went up to 80, 90%. So I know we've been talking a lot about intracranial vessel wall imaging, but to go into carotid vessel wall imaging, this was the plaque at risk study by Aline Cooey and company, in which they longitudinally evaluated patients with carotid atherosclerotic disease and tracked for recurrent stroke events. What they found was that IPH, intraplaque hemorrhage, in carotid plaques was significantly associated with recurrent strokes, while ulcerations in plaques, something that can be seen on CTA, was not associated with recurrent strokes. And this is a point that I made to my colleagues at UW when they indicated, well, if we just documented ulcerations and other plaque features on CTA, we could very well stratify stroke. And the point is MR is really important. MRA, vessel wall imaging, is really important in terms of that stratification. So from there, what we did, all this data I presented, additional data that we'd collected at our institution, we collated it all together, and then we had a meeting between radiology, neuroradiology, and stroke neurology leadership to discuss what we wanted to do, how we wanted to implement vessel wall imaging. We went through a number of ideas. It's probably going to be most impactful in those patients with undetermined stroke etiology. Should we do it in just those patients? But the reality is, when you do that MR within a day or two or three, you don't know who's ESUS, you don't know who's cardioembolic, you don't know what potential other etiologies may be present. So we decided to do it in all stroke. And the reality is beyond ESUS, we've certainly found a lot of value in ESUS. We found value in other disease states as well that I'll talk about. And the next step was development and implementation of an appropriate protocol that was sufficiently efficient for our clinical workflows. And so the first thing is, this is a study that we did in which we compared image quality for Dante space, blood-suppressed vessel wall imaging versus non-blood suppressed conventional space. And we found that there was significant improvement in qualitative metrics across the board, most importantly being blood suppression, while the quantitative metrics were not different between the two in terms of SNR and CNR. And just to provide you an example, here's a case where vertebral artery is completely clean on the pre-contrast. On the Dante blood suppressed technique, lumen's completely clean. But on the conventional T1 post-contrast, you can see that there's a flow artifact. It looks like it's adherent to the wall in that vertebral artery that currently could be confusing with a thrombus or some other lesion within the artery lumen. So we built our protocols. We built in Dante. Our resolution was slightly lower at 0.7 isotropic. We did have coverage of the head and the neck. And this protocol that we did, we heavily leveraged compressed sensing with it. Acquisition time was 3 minutes pre and 3 minutes post. And then what we did is we took our whole stroke protocol, which was 16 minutes, and we leveraged acceleration across the board for all sequences. And when you combine the vessel wall imaging, it went from that 16 minutes for the legacy protocol down to 12-minute scan time. So we actually improved our efficiency while adding vessel wall imaging, improving the quality of the imaging that we were providing. And so just to provide a few examples and some discussion, this is an abstract that Ahmed Safwa, one of our former fellows, is going to be presenting tomorrow. But in terms of these acute stroke patients, we found that there was a strong correlation in patients with AFib of having intraplaque hemorrhage. It actually existed in almost 10% of patients, both had AFib and IPH in the stroke setting. In addition, for patients with AFib, almost 30% of those patients had intraplaque hemorrhage, just indicating that usually these patients don't have one etiology. Once a patient has AFib, most institutions don't do vessel wall imaging in these patients. Once they have AFib, we assume that's the etiology and we don't look any further. But it is a complicated landscape that we're looking at in terms of stroke. And so here's an example of a case of a patient with AFib, small infarct involving the left MCA territory. We can see there is some plaque involving the carotid bulbs, but less than 50%, so nobody would be worried about it, right? This is just a little plaque in an old person. But then when we did the vessel wall imaging, you can clearly see that there is intraplaque hemorrhage abutting the lumen within that plaque right at that carotid bulb. Here's another case. This is a patient who a number of years before had undergone spine surgery. And at the time, his carotid bulb looked pretty normal on CTA. Came back to us with stroke symptoms referable to the left MCA. And at that point, the CTA showed calcified, non-calcified plaque as well as an ulceration. Left MCA territory infarct that we can see here. Vessel wall imaging is a little affected secondary to the hardware. We can see there's that plaque. If we look at it on the sagittal view, we can pick it up a little better along that undersurface of the plaque. There is intraplaque hemorrhage within that plaque and a little bit of an ulceration there that we saw in the CTA. But in this setting, as we mentioned, that IPH is predictive of future strokes, that ulceration may not be. Now transitioning to a patient who presented with right MCA stroke symptoms, a middle-aged patient, and what we see is that right ICA is occluded, but we did not know whether that was secondary to spontaneous dissection, atherosclerosis. That's always a question we end up getting in these patients. What's the cause of that occlusion? You can see that there was an M2 MCA occlusion as well. Right MCA territory infarct. Vessel wall imaging and MRA clearly showed that there was T1 hyperintensity throughout the wall here, consistent with a dissection. CTA showed occlusion, but it was actually still a patent lumen, which is important for prognosis. In addition, it did extend into the intracranial component of that Petrus ICA, which you see on the vessel wall imaging, but you don't see on the MRA. And the interesting component is, as we saw on vessel wall imaging, that lumen was still patent, while on CTA it was occluded, this baseline CTA. 8 months later, we did a follow-up, and that lumen opened up again. Right here, you see it looks like a pretty normal ICA. And that's another important factor. When a dissection is occluded, it rarely opens up again. So in this setting, this supports the idea that the vessel wall imaging visualization was more accurate than the CTA visualization. And then one of the last cases I'm going to show, there's a patient who was in the setting of trauma. And then on CTA, this was interpreted as a grade 1 dissection, blunt cerebral vascular injury. And that usually buys a patient a number of days in the ICU and sequential TCDs and treatment and follow-ups and all those sorts of things. Vessel wall imaging showed the wall was completely normal, no dissection here. So that certainly saved the patient a lot of care and a lot of potential risk in terms of being hospitalized. The last case I'm going to show here is a patient with bilateral basal ganglia or corona radiata infarcts here. MRA was completely normal in this patient. And on vessel wall, on the MP RAGE here, post-contrast, it was called normal. I think most people looking at it quickly would call this completely normal. When we did the vessel wall imaging, we saw multifocal areas of curvilinear subcortical enhancement in that kind of perivascular distribution. This patient was treated with immunomodulation after this exam, and that completely melted away. We're thinking it's probably a small artery inflammatory vasculopathy because that's how they behave. Once they get steroids, all that enhancement melts away. And certainly the vessel wall imaging was helpful in terms of depicting that and changing patient management. So comprehensive vessel wall imaging can improve stroke etiology diagnosis, and it can contribute to secondary stroke prevention. Multiple potential etiologies can and frequently are present in a patient. And in that setting, vessel wall imaging can really help in terms of better directing patient care and treatment. Thank you so much. Just the VIL at UW. And this was supported by an NIH grant as well.
Okay, thank you very much. The next speaker is Huijun Chen, who will give us speech about the quantitative MR vessel wall imaging. That's welcome.
Thanks for the introduction. I have nothing to declare. My talk would be focused on the technical. So for the introduction, I think previous two speakers actually give a pretty well clinical relevance of the vessel wall imaging. My talk is focused on quantitative vessel wall imaging. So let's look back to, we call it traditional vessel wall imaging. It's actually provide more information other than MRA, which is only provide stenosis. What we usually do for vessel wall imaging is we actually scan for 2D or 3D multi-contrast sequences, and then we process and review it. Basically, we trying to build a 3D model of this artery, including plaque and the lumen and the composition in that. So if we usually we do vessel wall imaging, we assess the plaque risk based on two kinds of parameters. First one is plaque burden, which you can use thickness, normalized wall index, and other things. Another thing is the plaque components, including necrotic core, intraplaque hemorrhage, calcification, and others. But the challenge of the vessel wall imaging is related to the weighted imaging itself. So the first thing is the contrast is variance based on the scanner type, the coil, and the imperfection of the system itself. So this is a quite traditional challenge. It's a common challenge for all weighted imaging. It will cause some problem in longitudinal studies. And the second thing is usually it's a pretty long scan because we need multi-contrast, multi-weighted imaging. And also because of that, if we do carotid artery, the thing is it's a soft tissue, and the patient would move, and the review would be complicated because of the non-rigid motion between the weightings. So that would cause a long processing and review time to generate this. Why we want to do quantitative vessel wall imaging? It would overcome some of the traditional vessel wall imaging's problem. First thing is if we use quantitative imaging, it also can be used to identify plaque components, including intraplaque hemorrhage, lipid-rich core, or calcification. Another thing is quantitative vessel wall imaging actually may provide some new information of the plaque itself. The first thing is the ion deposition, which is can be identified and can be quantified using T2 star mapping or QSM. And there's another recent study actually using QSM to quantify elastin and collagen of the plaque. There is another way to quantify the risk of the plaque is we use quantitative parameters directly as the risk factors. All those studies, including T2 star, T1, and even combine use T1, T2, and T2 star mapping without identify any plaque components itself. That could result quite direct evaluation of the plaque risk. But quantitative vessel wall imaging actually face some technical challenge. The first thing is because we want to do vessel wall imaging, so blood suppression is a key technique compared to other traditional quantitative imaging. The second thing is actually quantitative imaging is very hard to do because it's also still needs multiple scans, usually involve different scans with different flip angle, with different TE and other things. So that's also caused misregistration around among the scans. So I will go through the technical development into these three categories. The first thing is the multi-scan quantitative vessel wall imaging. The key technique is the blood suppression. Usually we do this, the blood suppression technique is quite similar to vessel wall imaging. So such as the IR, inversion recovery, the 3D merge, MSDE, or something like that. So this is all the previous vessel wall T1 quantification using multi-scan. So you can see for T1 quantification, you use quite a traditional variable flip angle, inversion recovery, and Luke Locker. But you need to add some blood suppression techniques. Similarly, if you do T2 or T2 star quantification, it's still you need acquire several TEs, and also plus a certain kind of blood suppression technique for example, the DIR technique or MSD technique. And for QSM, it's quite similar. I will go through quickly because of the time. But also, recently, a lot of people found that we can do multi-parametric vessel wall imaging other than if we use multi-contrast, multi-scans. So for these two works, they use MSD and the variable flip angle to try to quantify T1 and T2 at the same time, or T2 star at the same time. The recent development of quantitative vessel wall imaging goes to single scan quantitative imaging. So all the techniques are trying to shorten the scan and processing time by we just acquire the image using one scan. So this is a study from our group. We developed this technique called GoSnap. Basically, it's inversion recovery plus 3D radio crucible acquisition. Because every radio line actually goes through the center, so we can acquire different TI times and by the reconstruction and do a mapping from it. To further facilitate the clinical usage for this technique, we further develop AI-enhanced reconstruction. We call it Dante, and we can further shorten the scan time and shorten the recon and the fitting time. Furthermore, we developed this T1 and T2 quantification sequence. We call it simple, using one sequence. And other group actually have pretty similar strategies. For example, this group using one sequence to quantify T1 and T2 star mapping. And this is from Professor Xie Yibin. They have this Q match technique, actually can have T1 and T2 mapping from one sequence. Several years ago, our group actually developed this T1, T2, and T2 star quantification using one sequence for carotid plaque quantitative imaging. And lastly, I want to give some new developments because the new developments, I think, basically major on three categories. One is we're using single scan quantitative vessel wall imaging sequence actually generate weighted image. So that means it could be a one-stop vessel wall imaging solution. And the second is a lot of studies actually using higher field, 5T or 7T. and also extended that vessel wall imaging to other vascular bed, especially intracranial vascular. So this is a study we actually using our simple, which is invented originally for T1 and T2 quantification in one scan, but we can actually generate MRA from it and T1 weighted, T2 weighted, proton density weighted, and also the T1 and T2 mapping from it. And this is a carotid study. We actually showed the agreement of our simple generated multi-contrast imaging compared with the traditional imaging protocol. They can identify the key plaque components pretty accurate, but with a much shorter scan time. So that means this could be a possible one-stop vessel wall imaging solution. And this is our initial attempt trying to do intracranial vessel wall, intracranial artery for our GoSNAP sequence. This is also on 3T. So you can see actually the MRA generated from GoSNAP sequence is pretty good, but we still need to trying to generate not only to see the MRA, but also trying to generate the multi-contrast, multi-weighted imaging from this acquisition. Similarly, the multitasking technique actually can do a pretty similar thing, but this paper actually is for aorta. It's another vascular bed. And for intracranial vessel wall quantitative imaging, almost 10 years ago, a lot of studies studies on 3T or 7T or even higher on 11.5.7T, they all do ex vivo, and they found that actually the intracranial plaque also have a lot of composition. It's not simple as we usually see. It's just a thickening or a little higher signal. Or other than that, they actually can identify different plaque components. But the problem of that is they are all ex vivo. How about the in vivo? So we actually trying to use previously mentioned our GoSNAP sequence, trying to do quantify the in vivally quantify the intracranial artery. This is two abstract. One is a native T1 mapping, and another is a contrast enhanced T1 mapping. So we both found the lower T1 values in symptomatic intracranial plaques, but for native T1, that means it could be caused by the ion deposition or hemorrhage. But in contrast enhanced T1, this could means the symptomatic plaque may have contrast agent deposition or have inflammation inside it. So this new work actually using a Dante plus MP2-rich sequence to trying to do intracranial vessel wall quantitative imaging, and this is an in vivo study. And we also we also did a preliminary study using T2, using 7T, sorry, and to quantify the T2 star mapping of the plaque. As you can see, actually on 7T, the intracranial plaque actually can be seen very clearly because of the higher resolution. And this is our initial attempt trying to do 5T GoSNAP sequence. And this is just the initial investigation. And this will be presented in the following power pitch in this session. So as a summary, I would say the multi-parameter quantitative imaging in one sequence could be a new trend in vessel wall imaging because it has multi-function. You can acquire quantitative and traditional weighted imaging at the same time using one sequence. The major technique including multitasking and the GoSnap simple and the simple star. This technique from our group, and this could be the next generation plaque imaging protocol. And also in this area, the vessel wall imaging actually developed from carotid to other vascular bed, especially intracranial arteries. And in intracranial arteries, higher field scanners could play a big role in the future. Thanks for your attention.
And thank you very much. And thanks again to all the three speakers in part one. Now let's move over to the moderators in part two, Professor Chen Yuan and Professor Elaine Cui. Let's welcome.
Hello. Yeah, hi. My name is Chen Yuan from University of Utah, and then also from University of Washington. My co-moderator is Dr. Elena Cui from Maastricht University. This part that the speakers, each one will have 6 minutes and also 2 minutes for questions. And then for the power pitch, each one has 3 minutes. Please keep your time. We're just about getting into our receptions, and this has been a long day, so we'll start. The first talk is a simultaneous MR imaging technique of carotid artery, perivascular adipose tissue, and vessel wall, a feasibility and repeatability study, and is given by Su-Wen Yu from Tsinghua.
Thank you for your attention. Hello, everyone. I'm Shuan Yu from Tsinghua University. My topic is simultaneous magnetic resonance imaging technique of carotid artery, perivascular adipose tissue, and vessel wall, a feasibility and repeatability study. Biological studies have shown that inflammatory changes in perivascular adipose tissue, which is called PVT, play a key role in the development of atherosclerosis. Clinical studies have shown that both vulnerable plaque features and PVT inflammation are independently associated with cerebrovascular symptoms. Therefore, combining the assessment of carotid PVT and plaque features may better stratify the risk of ischemic cerebrovascular events. As we know, MR imaging has significant benefits for assessing both plaque vulnerability and adipose tissue due to its multi-parametric imaging capabilities and excellent soft tissue contrast. Therefore, our study aimed to develop a simultaneous MR imaging technique for carotid PVT and vascular wall. The MR sequence design and scan resolution are shown in the figures above. Our new sequence includes an MSDE pre-post module and a multi-echo Dixon acquisition module. The MSDE was used to suppress blood signals, and the Dixon was used for waterfall separation during the imaging acquisition. In our study, 17 healthy subjects and 9 patients with carotid atherosclerosis were included, and 5 healthy subjects were selected for repeatability testing. All participants underwent carotid MR imaging, including MSD Dixon sequence, merge sequence, and Dixon sequence, and to test the reliability of our new sequence. We compared its vessel wall measurements with merge sequence and its PVT measurements with Dixon sequence. The vessel wall measurements includes lumen area, wall area, normalized wall index, and maximum wall thickness. The PVT measurements includes PVT area, area index, volume index, and PDFF maps. As shown the figures, for the bilateral carotid vessel imaging, our new sequence offers vessel imaging quantity comparable to the merged sequence as shown in the figures, and it clearly shows vessel wall boundaries and plaque components in the black blood water images. As for the water fat separation imaging, our new sequence also achieves effective water fat separation comparable to the M-Dixon sequence. This technique allows for the acquisition of black blood water images, fat images, and PDFF maps of the carotid artery and the surrounding tissues in a single scan. The intra-class correlation coefficient analysis show that our new sequence not only had extent agreement with the merged sequence in carotid vessel quantification, but also had a moderate to extent agreement with the M-Dixon sequence in carotid PVT quantification. The blind Altman analysis showed that our new sequence showed small biases in the quantification of all carotid vessel wall measurements, as well as PVT area, area index, and volume index. However, it showed a larger biases in PDFF assessment. The repeatability analysis showed that our new sequence showed excellent agreement in the quantification of carotid vessel wall and PVT between the two scans. In conclusion, the MSD M-Dixon introduced in our study had high resolution with rapid imaging and excellent reliability in carotid vessel and PVT quantification. The MSD M-Dixon sequence enables simultaneous imaging of carotid vessel and PVT in a single scan with high efficiency, reliability, and repeatability. Future work should aim to expand the imaging range, improve astrobic acquisition resolution, and include a larger patient cohorts to further evaluate the clinical value of our new sequence. That's all for our research. Thank you for your attention.
Thank you. This is now open for questions from the audience. I guess I can get started. This is a very interesting area of study. But if you look at the carotid area, that the geometry of the area is very complicated. So when you try to define this so-called perivascular fat region, how is that actually defined from location to location?
You mean how to define the PVT?
Yeah. Area.
Area. Okay. That's a good question. I'm sorry that due to the time limitation, I didn't clarify the definition of PVT. Actually, in PVT analysis, we expand the outer boundaries of vascular wall as a factor of 2, then the original and magnified the area between the original and magnified boundaries was identified as the region of interest, and the PVT was identified as the fat tissue in the region of interest.
So expand the outer wall based on the outer wall shape. You expand by a certain distance.
Yeah.
And that becomes the end of the so-called perivascular fat area.
Yeah.
What is the base of that? Why do you define that range? How do you decide on that range?
The definition was according to the CT imaging research.
It's a CT.
Okay.
Yeah. Any other questions? No, thank you very much.
Thank you.
Okay, so the next presenter is Cheng-Cheng Su from the University of Washington. who will present on the aspirin use is associated with reduced aneurysm wall enhancement in intracranial succular aneurysms, a large-scale multi-center study. So the floor is yours.
Yeah, thank you for the introduction. The first author can't come, so I will present for him. Unruptured intracranial aneurysms are focal pathological dilation of the intracranial arteries and can affect up to 3 to 5% of the adult population globally. And the rupture of the aneurysm causes subcranial hemorrhage and hemorrhagic stroke with high risk of death and disability. And the treatment of the aneurysm, including open surgery or endovascular treatment, but currently there is no medication treatment available. And inflammation play a key role in the formation and the rupture of intracranial aneurysms. And anti-inflammation drugs such as aspirin or statin may reduce the risk of aneurysm growth or rupture. The aneurysm wall enhancement on post-gadolinium vessel wall imaging is an indirect marker of vessel wall inflammation, and previous studies found it was associated with aneurysm growth or rupture, as shown here. This is the enhancement, and this is the aneurysm. And a few previous studies investigated the effect of aspirin and statin on aneurysm wall enhancement, but the results were controversial, possibly due to the small sample size, normally less than 100, and also a single center study design. And also the other risk factors related to the enhancement, like size, hypertension, and so on, were not adjusted due to the small sample size. So the hypothesis of this study is in a large-scale cross-sectional multi-center study of more than 1,000 patients, the previous aspirin and statin use associated with reduced inflammatory activity of the intracranial aneurysms, as shown as reduced enhancement of the vessel wall. The patient data were from 3 prospective registries and from 82 medical centers in China. And the enhancement was defined as no enhancement, focal, or circumferential enhancement. And the definition of the aspirin and the statin use was listed here. And in the focal cohort, we performed the multivariable ordinal logistic regression to analyze the relationship between medication use and enhancement. And we also do a propensity score matching, a one-to-one match after excluding patients using the other medications to construct this separate matched cohort analysis for aspirin and statin. And here is the basic information of the patients. You can see there are some focal and circumferential enhancement, and there are some common risk factors associated with enhancement like hypertension, aneurysm size, and irregular shape. We also notice the trend that the aspirin actually has a reduced enhancement, while the statin seems to be has, in the opposite, increased enhancement. And in the full cohort analysis, in the multivariable analysis, we found the hypertension, aspirin use, and irregular shape, size, BMI, and the location are independent factors associated with enhancement, while statin has a borderline significance. So for the propensity score matching, we do the one-to-one match, and we match the patient based on age, sex, hypertension, diabetes, dyslipidemia, aneurysm size, and we have 82 matched pairs in the aspirin group, and also 90 matched pairs in the statin group. So we can see as shown here, the darker blue means more enhancement, and we can see the aspirin use actually reduce the enhancement, while the statin use is increase the enhancement, but is not significant with the odds ratio across 1. But the aspirin is significantly associated with a reduced enhancement. So here is a case. On the top row is a patient with aspirin use. We found on the post-contrast vessel wall imaging there is no enhancement. Here's another case with statin use, and on the post-contrast vessel wall imaging we see there is enhancement. So in conclusion, we found the use of aspirin but not statins reduced wall enhancement in patients with unruptured intracranial aneurysms. And aspirin may reduce the risk of aneurysm growth and rupture. And future longitudinal studies are required to confirm these findings. Actually, there are ongoing randomized clinical trials in Europe, in multi-center study in Netherlands and Germany. The PROTECT-U is actually investigating the effect of aspirin in aneurysm growth and rupture. Yes, thank you for your attention.
Thank you for presenting this wonderful study with an impressive sample size. The paper is now open for discussion. Are there any questions from the audience? Well, to start with, I already have a question. So I guess this is a rather unexpected finding that patients on statins had actually more enhancement. So do you have any explanation for that?
Yeah, it's quite challenging. We are also kind of surprised to see why the statin has also anti-inflammatory effect, but it shows more enhancement. And we already adjusted for the other vascular disease or stroke or cardiac disease. I think it's quite hard to explain.
Okay, thank you. And I wonder, because you use black blood images, right? So use black blood images. So did that work well, or do you sometimes suffer from poor blood suppression so that it's difficult to quantify the enhancement, or is that valid?
So I think that's a limitation of the study because it's a multi-center study in like more than 80 medical centers. So although we have the MSD or Dante, the technique is very hard to implement in every hospital. So we have to use the product sequence. So we do see some flow artifacts, but so we can still measure the enhancement, but it's hard to know whether that's artifacts or true enhancement. That's a limitation.
Okay, thank you so much.
Thank you.
Okay, the next speaker is which one? So it's you.
Oh, I'm sorry. So the next speaker is not here, so we are moving to a presentation of the University of Washington again. And so I think it's the same speaker, yes. So welcome again. And the next presentation is about reduced perivascular cerebrospinal fluid pulsation in patients with ischemic stroke.
Yeah, so the first author can't come due to the visa problem, so I will present for her. So we know the 1/3 of stroke survivors develop dementia in the next few years. And we know the dementia is related to the waste clearance function. So will the stroke itself disrupt waste clearance function? That's an interesting question to ask. And from previous animal studies, people found the CSF clearance system is actually driven by the cardiac position. People started using the injection of contrast agent to trace the CSF movement. And we can see actually the CSF moves together with the cardiac pulse. And here is another video showing actually it moves step by step by the cardiac beat. And also in another animal study, people found the occlusion of the internal carotid artery I think in the rat model is found. The occlusion of the artery actually makes the CSF transportation also blocked. So how about in the human stroke? So the aim of this study is to investigate the impact of stroke on perivascular CSF dynamics in humans. We use a technique developed by the first author, Qiu Ting, is a dynamic diffusion weighted imaging, which can measure the versatile CSF. We we can see this labeled as artery in the green, and also the brain parenchyma in red. It shows how the position looks of different structure. Like the parenchyma has no position, and the artery, because of the very fast blood flow, it's on diffusion with the imaging, it shows black signal, and the perivascular CSF will show some moderate signal. And here another image is showing the arteries and perivascular CSF. The hypothesis is a stroke will reduce the perivascular CSF position on the lesion side, but not the healthy side. So the approach is we include 128 patients with ischemic stroke, and we specifically select unilateral MC-M1 stenosis to have an internal control. So we compare the stenosis side with the healthy and non-stenosis side. We include both acute, subacute, or chronic stroke patients. And here is the parameters of the sequence. Here is a case with actually very young patients with left MC-M1 stenosis more than 50%. And we can see the volume of the pulsatile CSF as shown on blue here is actually reduced on the left side compared to the other side. Here is the dynamics showing it. And when we average all the patients showing in this single figure, this is the patient have a lesion on the left, and this is the patient have a lesion on the right. And we can see the lesion side, the volume of the pulsatile CSF actually reduced significantly compared to the opposite side. And the reduction of volume is 11% overall. And if we look at specific regions on the PCA, actually is increased, possibly is a compensation effect. And from the MC, it's significantly reduced. On the ACA, there is no significant difference. And when we look at MC, M1, M2, we found the M1 where the lesion locates is no significant difference, but there is a significant decrease in the M2 part, which is a downstream. And we also found if we group the patients into the healthy and the less than 50% stenosis, the decrease is very small. If it's for more than 50% stenosis or with one side less than 50, one side more than 50, the decrease is much more. So in conclusion, we've found the first evidence of CSF precision reduction in stroke patients. It happens more on the downstream of the lesion, and the greater stenosis means greater reduction. And the implications are that disrupt CSF clearance may underline increased dementia risk. And longitudinal studies are needed to confirm this hypothesis. The potential impact is the dual consequences of stroke, both the reduction of blood flow and also perivascular CSF dynamics. I would like to thank my co-authors, the first author, Qiuting Wen from Indiana University, and also other co-authors and Mahmoud for his helpful suggestions. Thank you for your attention.
Well, thank you so much for presenting this wonderful study. There is time for questions from the audience. Well, then I have a question. I wonder, do you think it would also be possible to image the pulsation of the arteries, or is that too challenging of these small arteries in the brain? Because that is the underlying cause, I think, that reduce CSF clearance or not. And so could you also look at the pulsation of the artery itself, do you think?
Oh, you mean the position of the larger artery or like M1, M2, or even smaller artery?
Yeah, yeah.
Yeah, I think, yeah, that's a good idea. We can do both the 4D flow for the calculation of the artery position. Well, this technique is for the CSF because
Mhm.
on the DWI because of the B value, even a small B value will make the blood totally dark. So that's why it's not possible by this technique. But if we do two sequences like 40 flow or other technique, we can do that together. That's a good suggestion. Yeah.
Thank you.
I have another question that is, if you image these patients in the morning versus image them in the evening, do you think that there may be any differences of this CSF flow?
Yeah, that's a good question. We never do that, but that's maybe a good future volunteer study for the healthy people to check that. I mean, after the whole night's sleep, the CSF clearance may be different than during the after the long day. Yeah.
Okay, yeah, thank you.
Thank you.
Now we'll move on to the next speaker. And the title is a motion robust quantitative multi-contrast atherosclerosis characterization. And it's the speaker is Yibin Xie.
Thank you for
from
the
Cedars-Sinai.
Thank you for the introduction. And this work is mainly done by first author Meng Liu's PhD student. Unfortunately, he couldn't be here, so I'm presenting on his behalf. Let's see. We already know that carotid atherosclerosis is the major cause of ischemic stroke. And MR-based vessel imaging is very useful in identifying high-risk plaques. And it's perhaps still an area where MR-based method can outperform CT. And however, MR suffer from motion artifacts due to the long scan time, especially for multi-contrast approaches. One study reported that over 15% studies are non-diagnostic. So in our group, we've been working and applying this so-called Q-match technique, which provides sort of an all-in-one approach to give comprehensive plaque evaluation. However, even though it's one scan, it still takes almost 8 minutes, so motion could still be an issue. So we've been applying this technique in a multi-center study in the US, and we have found some cases in patient scans that motion is problematic. So we've been developing post-processing and reconstruction-based strategies to address that issue. And one of the approach is using this so-called motion binning, where we can analyze the navigator data in the acquisition and then cluster, generate the real-time reconstruction and cluster motion in the different motion states. And then you can separate that into different motion bins, which can be resolved individually with the multitasking reconstruction. And in the end, you can just select a motion bin with the minimal intra-bin motion variation. Another strategy we're developing or trying is this so-called a Rovere approach. This is a virtual coil combination techniques. It's shown first developed by King and al. At the USC. And this approach essentially calculates the optimal weights based on your selected region and of interest, and also the signal region, and also the interference region, where you can perform generalized eigen decomposition to help determine the optimal weights of coils in order to recombine them to basically help maximize the signal to interference ratio. Essentially, it's like a beam forming in the coil combination. This allows us to suppress the motion coming from out of the carotid area while maintaining high signal from the carotid area. So we have included 30 Q-match data sets from the DTAC multi-center study. All of them have various variable levels of motion magnitudes and types.
And each data set was reconstructed twice, one with and one without motion compensation. And we evaluate the image quality and also the precision measured as a coefficient of variation of vessel wall signal and T1, T2 mapping. So in this example shown on the top row is a MoCo image from the QMesh reconstruction, and looking at the normal vessel wall area where it can be well delineated with vessel wall, and also the T1, T2 maps are much more uniform and less noisy compared to the conventional QMesh reconstruction shown on the bottom row. This is another case where this is shown in the also a normal part of the vessel wall shows the much improved image quality and less noise, and this is especially the case for the mapping where without the MoCo post processing, it's almost cannot be identified for the vessel wall. So we also evaluated quantitatively the coefficient of variation in this signal for the uniform region of the vessel wall, and the coefficient of variation is significantly reduced, which suggests that the motion artifact induced signal inhomogeneity was decreased, and in the vessel uniform part of the vessel wall, this is significant for both void signal T1 map and T2 map. So to conclude, the proposed motion compensation strategy mitigates the motion artifacts and enhance the image quality. And we have observed improved vessel wall visualization as well as the precision of the T1, T2 maps. The future work are ongoing, including validating in a larger cohort, especially on the diagnostic performance of the plaque characterization, as well as ablation study for separating the contribution of different motion, the two strategies. We are also combining radio sampling to improve motion robustness. We would like to acknowledge the multi-center study, the DTEC study, which is conducted by 5 sites in the US and funded by both NIH and the VA. And thank you all for your attention.
Thank you. Any other questions from the audience? I have a question for you then. It's so the images are taken from patients in this. Do you have any experience of looking at so-called lesions itself in terms of improvement of T1 and T2 mapping?
Yeah, definitely. Actually, I had a slice. Unfortunately, it wasn't updated, so happy to show you afterwards.
Okay.
Yeah, but my impression is the image quality of the so-called weighted images appears to be improved, but not as dramatic. But in the mapping, actually, the differences are kind of night and day. So happy to show some example like IPH.
Yeah, that would be very nice. Yeah, I think. Any other questions? If not, yep. Thank you.
Thank you.
Right, so then we will continue with the power pitches. And the first presentation is from Vadim Malis from UC San Diego, with a presentation on carotid MRA using centric 3D FFE and black blood imaging with T2 prep before black blood pulses. So the floor is yours.
Thank you for the introduction. We received support from NIH and Canon Medical. So carotid MRA and vessel wall imaging remain challenging due to the long scan times associated with time of flight and the black blood imaging. So poor contrast between the vessel wall and dark blood as well as the surrounding tissue limits the visualization. And this study demonstrates use of zigzag-centric KY-KZ 3D trajectory with the T2 prep module or non-contrast carotid white blood MRA and the vessel wall black blood imaging. So for the white blood, we utilized centric fast field echo with the T2 prep module with effective T of 65 milliseconds to suppress venous and tissue signals. For the black blood, we used the 3D single-shot fast spin echo with the T2Prep model implemented before and after the black blood double inversion model. As shown here on the diagram, the position of the T2Prep was varying. And both sequences utilize centric KY-KZ zigzag trajectory, similar to the one shown on the bottom right. So for the black blood imaging, we optimized first with a simulation study with the goal to improve the contrast of the vessel wall over dark blood as well as the surrounding tissue. So two configurations for the T2Prep, one prior to the black blood double inversion and after, were used with the T varying from 50 to 800 milliseconds. So in the first column up here on the plots, this is the T2Prep placed before the black blood, and in the second column, the T2Prep was placed after the black blood. The results of the Phantom study were also close with the results that we got from the simulation. So as you can see here on the top, these are the example images that we obtained with the Phantom. So for the Phantom, we used water, milk, and cream to cover the large range of the T1 values. So for the water, the lone T1, milk, something similar to the venous blood, and cream, something similar to the muscle and surrounding tissue. You can see with the T2Prep placed before the black blood, we were able to preserve the signal intensities, while for the T2Prep placed after the black blood model, we observed the expected result with the regular T2 weighted images with a diminished short T2. So in vivo results here, starting from the left in A, the centric KY-KZ time of flight, and in B, the centric fast field echo with the peripheral gain, and we used here the T2Prep model with effective T of 65 milliseconds. In C and D, the black blood images, so those were acquired with the T2Prep placed before black blood double inversion with the effective T here with 300 on the top in C and the 400 at the bottom in D. So to summarize, for the white blood images, in under a minute scan time with the centric fast field echo and the T2Prep of 65 milliseconds effective T, we were able to effectively suppress main and background signals. While for the black blood images, we were able to regain surrounding signals and achieve good contrast between the vessel wall, surrounding tissue, and blood by placing the T2Prep before the black blood.
Right, so thank you. So the next presenter is my co-moderator, Professor Chun Yuan from the University of Utah, with a presentation on high-resolution 3D carotid vessel wall MRI without a custom-designed coil using deep learning denoising.
Yeah, thank you. That's Xiangjian Hou cannot come because of visa issues, so I will present this work. A little background of this is if you want to look at carotids, it seems to be there's a very good way you can get good images with a surface coil. But the problem is in clinical setting that setting this coil sometimes is bothersome. So the question is whether we can use this so-called reasoned denoising techniques to regain the signal, and therefore you can get decent images without the coil. And this is basically a sort of evaluation of what's available out there. And then on the Siemens scanner, there's this so-called deep resolve. And then there are also CNN-based networks. There were some other computer vision-based networks listed here. We actually particularly look at all these are the ones we look at together to see that which one may actually be useful for carotids. And this is the imaging protocol. So for the training of this is we actually acquire data based on existing coil with the surface coil. And then the other data set is the so-called noisy without coil data set from the same subjects. And then this is the training and then the results of the study. What you basically see is among these different approaches that this so-called RESTORMER seems to be performing the best, at least by looking at the images, comparing them. And there's some real numbers to back this up. In addition to this is that one of the subjects shown here is a samples of images from a real patient. And if you look at the first image with carotid coil and the last image with this so-called denoising results, they seem to be pretty similar. So in other words, that it seems to be that with this denoising approach, you may actually be able to gain some signal and then make the images, it's a better quality image. But also I think that we feel even just by looking at some simple samples like this, there are subtle image differences of what's in the original high signal to noise images comparing to this so-called denoised, prettier looking image with a so-called a little bit signal gain. And I think that this is certainly, if you were to look at this, is having more patients data training and with better performing algorithms, we may actually be able to get there. But there are still a lot of challenges, I believe. That is exactly because of, we are looking at a very small structure. And then in order to see it clearly, this kind of a beautification based on denoising, whether that actually is valid, I believe the jury is still out there. Thank you.
Thank you so much. We will continue with a presentation by Hao Chong Sun from Tsinghua University on simultaneous high spatial resolution, quantitative brain T1 mapping and MRA using 3D golden angle radial K-space sampling at 5 Tesla.
Thank you for your introduction. I have nothing to declare. Everyone know intracranial atherosclerotic disease or ICAD is a leading cause of stroke mortality and has a high risk for stroke recursion. MRI imaging, visual imaging is a useful tool to get the imaging biomarkers. However, the weighted signals limited the establishment of threshold and limiting the components multi-center study. As we know, there are many research showing that T1 hyperintensity is related to stroke, but their OR reported is very different. Meantime, the record of high resolution due to the requirement of a high resolution in vivo T1 mapping MR technique is very challenging, while ex vivo T1 mapping can be reported for ICAD. Based above, our aim is to develop a T1 mapping sequence for intracranial plaques. Our method uses GoldSnap in 5T field on a UIH Jupyter 5T scanner. GoldSnap uses 3D golden angle crucible trajectory, and it could provide bright and black blood contrast and MRA and the T1 mapping simultaneously. For results, this is our phantom study result. It could be said that the T1 mapping of GoldSnap has a high R2 square of 0.99. This is a case of young healthy volunteers. GoldSnap, the scan time of GoldSnap is 6 minutes for 40 seconds, while achieving 0.7 millimeters isotropic resolution. This slide shows the MRA imaging and the bright blood imaging. This slide shows the two different black blood contrast and the final result of T1 mapping. Compared with the imaging, GoldSnap imaging in 3T, we can say the MRA imaging of YT GOSAM could better display small vessel wall, and the SNR and the CNR around the small vessel image is higher than 3T. To conclude, the 5T GOSAM sequence could provide higher SNR for vessel wall imaging. In the future, there are more challenges of high field should be considered. The design of inversion pods should be considered for higher SAR and field inhomogeneity, and the B1 inhomogeneity should be addressed for accurate fitting T1 map. That's all. Thank you.
Thank you. The next speaker is Haoding Men, also from Tsinghua University. And the title is Application of Mask-Guided Hybrid Decoupled Fourier Block in Carotid Artery Wall Segmentation.
Okay, nice to see you, everyone. I'm Meng Haoding from Tsinghua University, supervised by Professor Li Rui. Today, I'd like to share my research in the carotid artery vessel wall segmentation with mask-guided hybrid decoupled Fourier block. Let's talk about background firstly. Nowadays, the advent of this stroke serves to the public attention to the carotid artery diseases. So accurate vessel wall segmentation is crucial for clinicians. However, manual annotations is quite time-consuming, and as for existing deep learning-based method, they mainly focus on spatial information processing instead of taking frequency information into consideration. And these images are from Beijing Xuanwu Hospital, which used for our training data. It consists for sequences of MRI, T1, T1 contrast, T2, and TOF. And this is our proposed MHD Fourier block. It will process features from the spatial domain to the frequency domain with Fourier transformation, F in here and F out here, and the Manhattan distance map here or here to separate the whole frequency space into several frequency bands. For example, if we set band number to be 2, we will get high and lower frequencies information, quite similar to high pass or low pass filtering in traditional digital imaging processing. After that, we integrate this plug and play block into the skip connection part of NN unit. As for the results, we try our method on 16 cases of carotid arteries. Just like the figure shown here, our model's predictions align better with manual annotations, and the matrix shown here indicates that our model outperforms the baseline across all components, both in outer wall and inner lumen. Due to time limitation, please ask me more details about the details of the method. That's all. Thank you for your attention.
Thank you. The next talk title is a Surface Coil Informed Deep Learning Denoiser for Carotid Vessel Wall Imaging. And Yibin Xie will give the talk.
Thank you for the introduction. Yeah, so this talk, this work was mainly performed by Li Xiao's PhD student in our group. I think the motivation was already kind of laid out already by Professor Yuan for the previous talk. We have to think the same problem, addressing it with kind of similar approach. But briefly, the conventional head and neck coil used widely shipped with every scanner is used almost universally for head and neck imaging. However, it provides limited SNR for the neck region, particularly, especially for high-res vessel wall imaging. But and people use all different designs of a specific carotid coil. In this case, we use this so-called neck-shaped specific coil. It can conform to the neck very nicely because they have different sizes, and it achieves 3 to 4 times SNR gain. However, the limitation is obviously the added cost of the coil and potentially some patient discomforts and reduced clinical throughput. The technologists, they don't really like it, and also the reliance on the expertise. So we are designing a deep learning-based denoising methods by learning basically the reference images, which is acquired using all the coils, of the combination of the head and neck coil and the carotid coil, while the input image, which is a noisy image, was reconstructed from the same data set, but removing the carotid coil elements. And we use a residual UNet to train the network, and we have designed an approach that can be applied for multi-contrast images in a generalized approach. And this is some sample images to show the input, reference, and different methods. The deep learning method is our proposed method, and the TV and anisotropic diffusion methods are conventional, not deep learning-based denoising methods. As you can see, the images shown, the proposed methods performs quite well in denoising while preserving the image sharpness much better than the conventional methods. So in this is a patient example where we saw a ruptured, the fibrous cap can be better visualized on the MPRH image with the reference and the deep learning-based denoised image, as well as on the TOF images, both of which has been denoised by our proposed approach. This is another case where there's also fibrous cap rupture with underlying IPH signal. We have an e-poster can potentially look at these images more carefully. So in conclusion, this study shows the feasibility of a deep learning-based denoising method for improving SNR with the knowledge of specialized net surface coils. And further clinical validation is obviously still needed. And then the proposed method does show promise in improving diagnostic performance. I'd like to, again, acknowledge the DTAC consortium and the funding resources. Thank you.
Thank you. The next speaker's title is Evaluation of AI-assisted compressed sensing in intra and extracranial MR vessel imaging. It's given by Ran Huo from Peking University.
Hello everyone, I'm Ran Huo, coming from Peking University Third Hospital. Today my presentation is Evaluation of AI-assisted compressed sensing in intra and extracranial MR vessel wall imaging. Atherosclerotic stenosis, known as a systemic disease, will develop in multiple vascular baths, which is a major cause of ischemic stroke. 42.2% to 82% of stroke patients have a coexisting plaques in intra and extracranial arteries. The coexisting plaques were related to recurrent stroke. Recent years, compressed sensing has been widely used in rapid MR imaging. However, its insufficient capacity may lead to uneasy artifacts. Artificial intelligence compressed sensing, incorporating AM modules, CX, alpha Fourier, and parallel imaging to introduce deep learning neural networks has been validated to be an effective method into the reconstruction process. This study sought to evaluate the value of in ACS in characterizing intra- and extracranial MR visible factors compared to CS. The inclusion and exclusion criteria of study population and the parameters of MR imaging protocols were as follows. Both qualitative and quantitative vascular analysis was performed on 2D cross-section slices at 5 locations on bilateral arteries. The typical case showed the intra- and extracranial MR visible images. There were significant differences in the subjective image quality ratings between ACS and CS T1, T2 weighted images. The wall SNR of T1, T2 weighted images showed significant difference, while part of lumen SNR exhibited no difference in all 5 segments. Significant differences were found in CNR between ACS and CS T1, T2 weighted images, as well as in wall lumen sharpness. It was concluded that ACS shortens examination time for intra- and extracranial MR visible imaging, while improving the image quality compared to CS. Thanks.
Thank you. Okay, this is the last speaker of the session, and the title is a carotid artery ROI localization pipeline in head and neck MRI based on slice classification and iterative non-maximum suppression, and it's given by Meng Haoding.
Nice to see you again. I'm back. This time, I'm going to talk about the carotid artery ROI localization. As for background, just like the picture shown here, this is a Y-shaped carotid artery, and this region is so-called plaque. When it ruptures, it may cause ischemic stroke. And this image is the ROI consisting plaque after our localization pipeline cropped from the whole row images. Whole row images. Whole row images, however. However, I'm a little bit nervous. However, for clinician, so it's quite precise localization ROIs is vital for early diagnosis. However, for clinicians, it may cost a lot of time in the detection of the bifurcation of the carotid artery, while for existing deep learning method, the diverse distribution of the plaque is also a huge challenge. And this is our this is the overview of our pipeline. The input row images will be standardized firstly, and will be sliced along with different directions to get slices images from different planes, such as axial and sagittal planes. And we will use the pre-trained ResNet classification network to determine this slice images contains plaque or not. After that, we will use iterative non-maximal suppression to find out the final candidate window, and we will use Cartesian product and Hadamard product to obtain the final ROI masks and final ROIs. As for the results, we try our method on 233 patients, and we allocate each carotid arteries with 8 ROIs. The result is quite impressive. It indicates that our method covers all necessary foreground areas while minimize irrelevant background and provides high quality input for following tasks such as segmentation, which I mentioned before. Thank you for your attention.
Well, thank you so much. And I would like to thank all the speakers again. And I would also like to thank the audience for staying with us so late in the day. On behalf of Judith, I would like to invite you to all go outside the lecture room and to join the welcome reception.